Hello, everyone. My name is Leon Freemuth, and I am presenting on behalf of Alessandra Dotso from St. Jude Children's Research Hospital, who is really an expert in galactosialidosis and sialidosis. And I'll just be giving a small overview and a little recent update on where we are in the therapeutic journey. So galactosialidosis has multiple subtypes. However, these lysosomal storage diseases, as most of us know, really function along a spectrum. There are early infantile forms, which are the most severe, have the most severe symptoms, tend to occur at birth or shortly after birth, and is quite fatal. There are more middle ground, late infantile forms that onset very early in life within the first year, have severe symptoms, but less severe than early infantile, and patients can live into adulthood. And then there is the least severe but still impactful form of juvenile adult um, that's onsets in the early teens and early adulthood. So going really way back in time to how the genetic cause of galactosialidosis was founded. Originally, this was one of Sandra's favorite stories to tell me about. It was kind of an accidental discovery when she was looking at what was at that time known as a combined deficiency of beta-galactosidase and neuraminidase in humans. They identified a protein by Western blot. And later on, when she had started her own lab, she worked with her first graduate student to express the DNA of what became known as human protective protein, cathepsin A. And this came out to the conclusion that PPCA actually works in a complex with neuraminidase and beta-galactosidase in the lysosome. Each one of these is associated with their own lysosomal storage disease. And PPCA really acts as a protective protein for the other two in the complex. Further investigation into the structure of PPCA showed that there's really a complex activation mechanism to this protein. It has a cap domain and a core domain. And what that means is that that cap has to be removed in order for that protein to be active. Taking that into consideration with known patient mutations at that time, they were able to devise that really the basis for galactosialidosis was structural, in that patient mutations often aligned with parts of the protein that were required for proper folding. This is reviewed quite well in a Chakotay review from 2013, in which you can see a lot of these patient mutations do drastically alter the folding and stability of PPCA. Overall, protective protein cathepsin A, or PPCA, is a soluble man-6 phosphorylated zymogen. It's activated by proteolytic processing. It is a hydrolase fold family member and a serine protease. It's active at acidic pHs. It is when it is a protease, and it can also function as a deamidase and esterase at neutral pHs. It does have a dual function in that it is catalytic and protective, and it is active in a dimer or in complex. So it forms as I said earlier, forms a complex with beta-galactosidase and neuraminidase to form the lysosomal multi-enzyme complex. It hydrolyzes a number of neuropeptides, including endothelin-1, angiotensin, oxytocin, substance P, and other biologically active peptides. It can work on its own, or it can work in complex with other molecules besides its known LMC, like LAMP2A, to mediate chaperone-mediated autophagy, which was found in this Cuervo 2003 paper that Sandra's lab collaborated on. But I think this is really what we all want to focus on and want to make a reality, is how do we treat galactosialidosis? How do we cure galactosialidosis? And there have been several attempts at replacing this enzyme through bone marrow transplant, gene therapy, enzyme replacement therapy in animal models of this disease. These all have proven to be very effective and successful. And so I know currently we're trying to get that into our human patients. I'm just going to go over the most recent therapy paper that came out from Sandra's lab, which was a AAV28 LP1 gene therapy model in mice. And the LP1 is a liver-specific promoter, meaning that this therapy is targeted to the liver to make the enzyme and distribute that throughout the body. And we tested the biodistribution of PPCA following this therapy, the resolution of disease in tissues, and the inflammatory response that occurred downstream of that, which there was very little, which is good news. Overall, we can see that there is an amelioration in pathology. So we see a reduction in accumulated sialic acids that's known to occur in these mice and in patients. We see correction of targeted tissues, this is the liver. Additionally, we do see correction in hard to reach tissues like the kidney and the brain. We see decent expression of the protein and correction of tissue morphology. Moreover, we see a limited immune response. We don't see any kind of antibody production against the AAV capsid or the protein itself that's made after infection. And that is really good news. And, oh, sorry. I totally lost my train of thought. So in all, the AAV28 therapy is what we used in our lab. However, when it comes to translating gene therapy from mice to humans, there's actually more efficient AAV subtypes, i.e. AAV9. And so now that Sandra's lab has moved into retirement, who is going to be next to take that up and to bring treatment to patients? And that's actually going to be currently Dr. Heather Gray Edwards and her lab, specifically one of her postdoctoral students, Jillian Gallagher, at University of Massachusetts Medical School. We collaborated with them previously during the last few years of Sandra's lab, and I know that they've taken that up and are moving forward with that. So that's really, really good news for all of the patients out there. With that, I would like to thank everyone that has been involved in all of this work throughout the course of Sandra's lab, starting first and foremost with Dr. Dotso, and then Dianta and Dr. Hu, that were involved a lot in the therapeutic work that I'll be presenting today, both in this session and the next. And everyone else listed here are former members of Sandra's lab that all had hands in this work over the course of the time she worked at St. Jude for over 30 years. And then, of course, we have to thank all of our collaborators that also made this work possible and all of the funding that was received over time. Thank you.
Let me just ask if we have any questions at this point before Lee goes on. Do we have any questions online or from the audience here? So let me just ask Lee, that's it's beautiful work that's been done in the animal models. And this may be an impossible question, but how far do you think we are from human trials of gene therapy for galactosialidosis?
Yeah, so I do know that Heather's group is trying to put together a pre-IND right now. Sandra, at one point at St. Jude, had a lot of preclinical work together. Um, it's really very close, I do believe. It's very close to coming into fruition. And then, of course, there is the waiting period to go into to getting approved for those clinical trials and things like that. But I know that Heather's group and Sandra always is commenting on that is they're working very diligently to get something started as soon as possible.
Thank you, Lee. And a follow-up to that, assuming an initial trial would be mainly in terms of safety and dosing. But one of the issues we'll be addressing a little bit later, but which I guess would be considered in a trial and is very relevant to gene therapy, is what outcome measures might be used to assess the efficacy of therapy. And again, I'm not putting you on the spot because it's perhaps not what you do, but I'm just interested to know if there's been some thought given to how one's going to measure the effectiveness of this sort of therapy and who the target population might be.
Yeah, so I know one particular challenge that I've discussed a lot with Sandra during my time working with her on therapies for these lysosomal storage diseases was how rare they are and how do you get a large enough patient group together to run a clinical trial. Within the United States, there are systems in place with the FDA that do allow for kind of emergency uses of therapy or these pre-INDs that can target smaller groups of patients. So I do believe that they're trying to go through a less standard clinical trial route, in which you don't have the requirement to have such a high patient number to go through the FDA clinical trials require many, many patients to go through the different levels of uh, clinical trials, phase one, two, and three, before they'll put a medication out on the market. Um, However, there are some other routes that require less patients. I believe that is how the UMass group is trying to go. In terms of output readings, that's a very good question, and it is not my area. I would speculate that you could look at reduction in sialic acid levels. That's pretty non-invasive. You can get that from urine samples, and that would be a pretty positive indication if things are moving in the right direction. I think other than that, you would be looking at amelioration of the physical presentation of symptoms in patients.
Thank you, Lee. That's very helpful. So it sounds as if perhaps using a biomarker, as you said, such as sialic acid, might be a route potentially to accelerated approval using that pathway and then subsequent follow-up of the patients. And again, I appreciate your addressing this because I know that's not specifically your area. Any other questions for Lee on this? Oh, yes, please, Dr. Wolf.
What age did you inject the mice and what route did you use?
So we used, I'm going to go back in my presentation here. So these mice were actually injected at multiple time points. They were injected around 1 month for the primary publication of this story. However, they did test the efficacy of injecting at multiple time points. In general, the earlier we injected mice, the better the long-term outcome was. You could see here in this figure, we injected at 1 month and then collected tissues at 2, 4, 7, and 13 months post injection. And it was a really robust. We injected by tail vein, so intravenously. So this is a systemic injection, and can be done quite easily. When you translate that over to a human patient, this would be like when you get blood drawn, through a standard IV route.
Thank you very much, Lee. Uh, no further questions at this point. Perhaps we'll move on to the next presentation.
Thank you. So I'm Chardash Chambalat, and I am a ISMRD board member, and then I'm also I've set up an organization called Galactosialidosis Network, and I'll tell you a bit about that later on. But ultimately, I think first of all, I am an ISMRD board member, which has provided me a platform to do lots of other good things. And so I just wanted to kind of emphasize the importance of ISMRD. Hopefully this machine is working, Abby. Let's give it a try. You might need to press it first because it's not working yet. Okay. So, first of all, I'm really glad that Lee has provided a lot of the technicalities. It gives me the chance to talk about mainly my experience and what I am trying to achieve, and just kind of talk about our journey. Today, I just want to, again, go through a background on galactosialidosis. I know Lee has covered probably more in the technical terms. I'll probably be kind of covering it from my understanding, and hopefully families here will be able to kind of understand it better from my experience. And what's key, and what I want to talk about today, is international collaboration. I think there's a lot of things that you can do in life, but you can't kind of achieve the kind of powerful impact unless you're working with people, unless you're organized, unless you're kind of putting the pieces together. And so international collaboration means a lot to me. Patient advocacy is so important because without it, it's really difficult to drive things forward. As I always say, scientists are great, doctors are great, but sometimes they don't have the passion that we do. They don't have the capacity because of probably a lot of other work that they're doing. So patient advocates, international collaboration is so important to get things over the line. I want to talk about some of the therapy options because I think that was what was driving me, because I wanted to find a cure for my daughter when she first was diagnosed with galactosialidosis. So for me, it was kind of understanding what I can achieve in the long run to save my daughter. And today, just to sum it up, it'll be, we do have an option, and Lee has just referred to AAV9, and I'll go through that. I've got 10 minutes, so I really need to be quick. Oh, Abby, it's not working again. Oh, yeah. Okay, now it's working, Abby, so you don't have to. So this is Clara Lauren Jumbolat, my daughter. She was born on 30th of June 2021. Just wanted to share a bit of photos of her, what she looks like. And we had a very amazing time together, at least for the first 18 months. It was just very normal. She was born normal. Now looking back, there might have been some signs, but overall, the way she appeared, the kind of the milestones that she was ticking off, it all looked fine. And I think we didn't have significant worries. But now, obviously, with hindsight, we can see that there were some clues. For the first 18 months, we celebrated her first birthday. So the photo at the bottom, my wife, myself, and Clara. It was just an amazing time. It was something that was surreal for us. It was something that we were so keen to have a child, and it was working so well for us, and we were really excited, really enjoying it. And I just wanted to share a couple of videos just to give you an idea of how she was when she was born in the first 18 months.
Clara, are you ready? Clara, are you ready? Go.
There was a couple of other videos I'll play at the same time, so we don't lose a lot of time.
Clara, are you ready?
So unless you're an expert in this field, it's really difficult to see that she has a storage disorder. For now, me looking back, I can see some of the signs, but at the time it just wasn't very obvious. And so it all started in December 2022 when she had a descending stomach and hernia, and something just didn't look right. And she started to not meet some of the milestones. She just wasn't strong enough to walk. So we thought there was something wrong. So the first thing that we noticed, and when we went to the hospital, was that there was protein in her urine. We thought actually we might be able to pass this through medication, but one thing led to another, and then in the next 2 months we had to do a genetic whole exomic sequencing, and we discovered that she had Galactosialidosis. So a bad copy of mutation of myself and my wife, we're not related, was passed on to her, and she was diagnosed with late infantile Galactosialidosis. And our world turned upside down on that day, because it was just all the uncertainty. But I'll just come, and obviously Lee has covered this, but there's 3 types. And obviously it's very easy for everyone to categorize illnesses. It just makes life easier. But I don't think it's always as simple as that as well. There's kind of crossovers as well. So my daughter was late infantile, so kind of, you could probably say type 2. And mainly they don't die before the age of 1. So with early infantile, with most of the cases that we've seen, they do die before the age of 1. But I have reached out to so many Galactosialidosis patients. I probably know most of the ones who are alive. And I know that at least 2 early infantile patients who are now 4 or 5 years old. So it's not as simple as, well, they'll definitely die before the age of 1. It doesn't really work like that. And obviously the data set that we have, I think, I went through loads of research papers, and I think I've seen max 150 kind of patients reported across the world. So with a data set of 150, it doesn't give you enough to be able to have concrete conclusion. But early infantile, they're the ones who kind of have a more severe case. They don't always make it before the age of 1, but not always. In our case, my daughter was late infantile, and we thought that she wouldn't die, and yes, she would have challenges, but we didn't think that she would kind of lose her life. There were kind of issues that we were kind of monitoring, and her biggest issue was a kidney failure. So we were in the hospital nearly 4 or 5 days a week on dialysis. It took out so much time, and I think that was our biggest issue. But at the time, we were going to have a kidney transplant, and we thought that we would overcome that, and then we would work on a long-term solution, which was a gene therapy. And the third type is juvenile, and 80% of the Galactosialidosis patients are from Japanese descent. I haven't been able to kind of reach out to a lot of the Japanese patients, but most of it are from Japanese descent. But you could also argue that it's slightly a different disease, because what the symptoms that they're experiencing are slightly different, because they're generally the symptoms are picked up when they're kind of teenage years. So you could argue that it's a separate disease as well. But at the moment, the general consensus is there's 3 types: early, late, and juvenile. So when I was first told about the disease, I knew that I had to do something about it. I couldn't sit. I wanted to look at long term. There was no platform around the world that could help me. I thought I needed to start thinking of doing something, but then I realized that there was a platform who could help me, and ISMRD was the one who provided me a platform to be able to do a lot more and give me the opportunity to reach out to individuals and organizations and scientists I couldn't. So I am so grateful that, for example, Carolyn noticed my work and said, why don't you come and join and represent one of our diseases that we represent? And that was Galactosialidosis. At that time, obviously ISMRD was covering Galactosialidosis, but we weren't so active. And I think with my participation, we became more active, and providing this platform through ISMRD was really helpful. But I don't think it was enough. So I felt like it was necessary to form a separate group called Galactosialidosis Network, which just focuses on Galactosialidosis, but it draws all of the information, scattered information across the world, all of the good things that have been done, all of the main scientists, doctors, and all the research papers into one website. And this is, so I'm from London, and we're kind of organizing this and kind of promoting this through London, but it's got an international reach. So there's various stories around the world. I won't go into the details. So I was saying that one child, Bella, the first kid from Germany, she is actually one of the first. She's had a bone marrow transplant, probably one of the first in Europe. We know another child who's had a cord blood transplant in China. We're still looking at whether the outcomes are positive. Her enzyme levels are pretty good. The next kid, Yusuf, is from Turkey. He's early infantile, but he's 4 or 5 years old. He's got a renal issue. I won't go any further, but do go on to our Galactosialidosis.org website, and the stories are all there. And all the stories, all the symptoms have different kind of way of manifesting. So when I first discovered Galactosialidosis, I needed to understand if there was anyone out there who had done the work. And Sandra D'Azzo is the brains of the research in Galactosialidosis. I don't think we would have made any progress if Sandra D'Azzo didn't do that work that she did over probably 10, 20, 30 years. And so she is a massive inspiration to us. Even though her lab has closed and she was at St. Jude's Children's Hospital, luckily it was moved over to Boston's Children's Hospital to Heather and Miguel and Jill that Lee was just referring to earlier on. So what we did was we did a bit of international collaboration. So even though the lab in St. Jude's Children's Hospital closed, all the information, all the knowledge, all the experience, all the viruses and AAV 8 and 9 was passed over to these guys, Heather, Jill, Miguel, Mary Alice, who've got patients. And they were so passionate and excited, and they were willing to do something about it. They really wanted to find a treatment. My story and the stories of others connected, and we were able to move on. But we didn't leave it at that. We wanted to identify all of the doctors across the world. So this is our doctor in the UK, Great Ormond Street Hospital, the kind of T-shirt I'm wearing. That's where my daughter was treated. It's one of the best hospitals I can think of, and we were really lucky to be there. We've got a doctor in Germany, Eugene, kind of couple of doctors who've done bone marrow transplant, the first in galactosialidosis. We've got a doctor in China. GDPR isn't a massive issue in places like China. I could even get through to the family members, but I don't know whether that's a good thing for patients, but it really helped me to kind of reach out to doctors and patients in China. We've got a Spanish doctor who's got patients, a doctor who's got 7 galactosialidosis patients, who had a paper, and has actually patients who are going to university. So that was giving me a massive hope that we could have a future for my daughter, especially if we found the gene therapy. And yeah, Roberto from Portugal, kind of Saudi Arabia, Turkey. So we were able, these are the main guys. If you want to talk about galactosialidosis, these are the main guys in the field. And we were able to bring everyone together. And we looked at various potential treatments. So bone marrow transplant is a possibility, repurposing a drug in Germany. We looked at Vanglastats by Sanofi, which I don't think it would work at all. But these are all of the options that we looked at. Again, the enzyme replacement therapy, which JCR was looking at one time, but it was really an initial stage. Emil Kakis from Ultragenyx, you'll probably know, was working on Alzheimer's, and the vector that they were using is PPCA, and we thought actually that could be helpful for galactosialidosis, and that was an option, and it's still an option. There's various other, damn, Abby, you need to, I don't know what's happened. Yeah, so again, we've met doctors in Japan. We're looking at lentiviral, probably I would say lentiviral might be the best, but there's no research behind it for galactosialidosis, so we had to make a decision, and we couldn't prioritize that. But ultimately, it was the gene therapy of Dr. Sandra D'Azzo, and I think that's the key. But when we first looked at this, we were looking at AAV8 at the time, and it was purely for galactosialidosis. The disadvantage of that was it didn't pass the blood-brain barrier, But even though we actually submitted a pre-IND, we had a response from FDA, and we were really ready to do a human trial, but we didn't really have the funding. We did make a couple of funding applications, but it didn't really kind of go in the direction that we hoped. But then we lost my daughter, and then at that same time, Heather and the guys in Boston's Children's Hospital were working on AAV9, and that was penetrating the blood-brain barrier, but it was also actually having a massive good impact on, as far as we understand, on C-alidosis and galactosialidosis. So with AAV9, we could potentially treat galactosialidosis and C-alidosis. So what I did was I teamed up with the C-alidosis patients group and our patient group that we kind of I'm actively involved in, and we thought this was a better kind of direction of travel. It's going to delay us slightly, but I am extremely hopeful that by maybe next year, we will be able to have a human trial. And Lee recently mentioned. So yeah, my daughter, unfortunately, isn't going to benefit from this because she died on 6th of March 2024 because of a failure in heart. There was too much storage and toxic built up in her heart, which we didn't expect at all. And then suddenly she passed away. But so this is a badge that we produced when on her funeral. My daughter was really enjoyed going to the park and feeding squirrels, and this was the badge, and this is now kind of our logo. What I just wanted to kind of end here by saying that I am so hopeful that we will be able to make history, and because all the kind of resources, the platforms, the passion, I think all the links have come together for us to be able to make a massive change. And as I say, my daughter opened up a chapter for myself, and I can't close that chapter until we can find a cure to ensure that other kids in the world don't suffer what we have suffered. And I think we're so close to that, and I can't turn my back on this. I can't say I'm going to walk away because my kid isn't going to be saved. I know that I could do a lot more, and I feel like it rests on my shoulder and the shoulders of other family members to make a difference. Even in a difficult time like this, I know that we will be able to take this forward, and we will be able to save a lot of kids. And I'm really hopeful, and I will be here until we achieve that. Thank you.
Thank you. That was beautifully done, very inspirational. Thank you for your work and for sharing your journey. Questions and comments?
Thank you very much for this story. My name is Sarah Cox. I currently a patient education liaison with Chiesi, but I've been a genetic counselor for almost 40 years. The stories that all of you are telling really get my heart, okay? But two of the things I want to say that I've always told patients when we make very complicated disorders or, diagnoses. One is that these genetic diseases, they don't read the book. They don't know how to present. So I loved your story about, hey, we're categorizing these into 3 parts, but it doesn't necessarily follow that path. And we can't always decide and make decisions based on books, right? So again, remember that these genetic disorders don't know how to present because we're just writing what we know. The other thing I tell people is that the more we learn about genetics is the more complicated it becomes. So it never gets easier to understand, interpret, make decisions about. So I think those are 2 things over my career that I feel have really helped families take away what providers are telling them. So that's just my 2 cents.
Thank you very much for that. Any more comments from the floor or questions from our online audience?
Abby, I'm happy to do the survey results as well if we wanted to put that up. I probably feel like I might be more kind of familiar than Mark is, because it's just what happens is with patient advocates, unintentionally, you feel like you have to become the experts because if you don't, it's difficult to kind of tell your story. So we did a few, just want to look at that survey results while Abby kind of puts that up. So hopefully everyone can see this. So with for example, my daughter had the late infantile, and the argument was that there isn't a neurological decline. And again, it's a very generalization. Again, for example, there are patients in Bahrain who's going to university. It doesn't always necessarily say that, yes, there will not be any neurological decline. But some family members, especially early infantile, they are concerned about the neurological decline. I felt that my daughter was doing pretty well in terms of meeting some of the milestones, but it's very difficult to say it doesn't have an impact. Organ dysfunction, yeah, renal failure, heart failure is probably one of the key ones. But again, it depends on which type that we're looking at. With my daughter, for example, we felt like the growth was an issue, but we don't know whether the growth was an issue because of renal failure, whether if she had a functioning kidney that it would have been different. But I think overall this is the kind of most common symptoms that patient families have mentioned. Maybe the next slide. So yeah, desire for improvement. Obviously, from our case, it would have been important to improve her kidney. And yes, organ disorder is a massive issue that we need to improve. I think, yeah, it's probably saying the same thing in the previous slide, neurological decline. Again, it depends on which type, because, for example, with the juvenile version, up until 16, 17, patients it doesn't seem like they have a neurological issue, but after a certain point, we are told that there is a neurological decline, especially on the juvenile version, type 3 of the disease. So yeah, these are kind of some of the improvements that patient families would want to see: organ disorder improvements, kind of neurological decline, and so on. Maybe next slide, Abby. Yeah, I think, yeah, the emotional impact, 67% have said the burden on caregiver. Obviously, we were extremely lucky in the sense that we didn't have the financial burden because we have a national health service in the UK that's free at the point of use. And so we didn't kind of feel that. We felt like we were in a care. But I've been to other countries like Turkey and various other countries who there's a massive financial burden. Just going on to dialysis each day will probably be taking a lot of burden on families. Yeah, burden on patients. I think our biggest issue was, and I see with all the other patients that I'm kind of dealing with on a regular basis, is the physical limitation, not being able to walk, not having the strength. And again, it's kind of reflected in this survey result. And then the burden on siblings. I think the reason that there's about 67% NA is because they probably don't have a sibling as well. Like in our case, we didn't have a second child. And the next slide. And I think the result here kind of really shows that obviously the lack of the kind of the barriers to galactosialidosis, lack of treatment options. I think there are a lot of treatment options now, but the massive barrier to that is the finance. I think if you gave me 2 million today, I'm sure I'll be able to solve and find a cure next year. It's mainly the funding, but again, I'm very confident that we will be able to overcome that by next year.
Well, thank you very much. And as you pointed out, your lived experience, I think, really means a great deal in interpreting those data. Before we go on the last part of this, any questions or comments? Okay, it looks like we have some online.
Can you see that okay?
Yeah.
The question?
So the first one is, which I think I'm going to defer to you. In your experience, are doctors well informed on genetic disorders and have the resources to address symptoms?
So yeah, Jaren's questions about so when you go to your local doctor, no one has even probably heard the disorder, and even if they have, they probably heard it on the just in a textbook. But I'm not expecting them to be the expert. It is so rare. I think with galactosialidosis, as I've said, there's only about potentially 150 recorded in research papers. Individuals living alive. So yeah, I don't think doctors are have a good understanding, and that's why you need to go to specialists. I think what has been difficult, and I think most family members experience, is you can see that there is an issue with your child, that they are facing something that just doesn't seem ordinary, and you want to address this, but most of the time, again, because of lack of resources, because of doctors' capacity, because of the world that we live in, where unfortunately kind of money is the kind of driving force of a lot of our decision making, that doctors kind of dismiss it. And they say, no, that's fine. We actually took our daughter to private care, kind of checkups, because we just wanted to make sure when she was 3 months. And she was diagnosed when she was 18 months. So it shows you, first of all, yeah, there's a lack of knowledge, but there's also, there's a lot of kind of like, well, actually, it'll be okay. You don't need to worry about it. And I just feel like doctors need to just try and have some sympathy and empathy and say, well, actually, what is your concern? Let's do this test. And I think that was the troubling that, or the issues that we experienced during that time.
Thank you. Thank you very much. Do we have another question here? Well, I agree you're an inspiration. So thank you for that. I think that would be unanimous. So let me just move on to the last part of this session, which is to talk about outcome measures. And I'm doing this on the fly for each session based on what we learn. And it seems to me that we have the same issues as with other subtypes of these very rare diseases, and that is that it's not a question of one size fits all. As has been pointed out, subdivisions into specific phenotypes are always of their nature artificial, and really disease is a continuum. It doesn't fit neatly into boxes, but it does seem there are certain common themes we could consider. And I think amongst the outcome measures we'd want to measure are clearly developmental milestones for younger children. That's something that should be done routinely in pediatrics. It should detect patients whose development is plateauing or regressing, depending on the circumstances. Clearly, growth is something that should always be measured as part of standard pediatric evaluation, and clearly that can be affected through multiple pathways in galactosialidosis, so simply height, weight. And as a neurologist, I always point out that head circumference is another vital sign. It gets forgotten many times, but it's very easy to do and should be done in every child and can give you a lot of information. I think digging down more into organ dysfunction, we've learned how cardiomyopathy and renal failure can be key features of this disease. And fortunately, we have many ways of assessing those. We can quantitate cardiac function very effectively and non-invasively with a number of echocardiographic measures. Renal function, of course, we can assess creatinine levels, glomerular filtration rates. We can assess urinary protein and other markers, as well as specific biomarkers of the disease, particularly specific oligosaccharides. And I think the other issue perhaps that we should consider in terms of outcome is always quality of life measures. These are non-specific, but can be very important. And, you know, in some clinical trials, clinical global impression of status as assessed by caregivers and clinicians, and in the case of patients who are able to complete the measure, can also be helpful, at least as secondary outcome measures. So those are some things that I would suggest would be helpful to consider as outcome measures for galactosialidosis, but I'd welcome comments from the real expert who's beside me and from members of the audience here in person or online. Any comments about that? Okay, all right. Anyone else in the audience have any comments about potential? Dr. Desnik, could we have a microphone for Dr. Desnik?
You know, I hear your story very loud and clear, and your motivation to do things about where there's a void. And congratulations on that. I think things are changing. And the reason is that when we do natural history studies, everybody talks about how long the odyssey is till they get to the diagnosis. Doctor to specialist to specialist before they finally get to somebody who's an expert on lysosomal diseases. And that's what happens. But now, with newborn screening for many of the diseases, And with whole genome screening, that's changing in this country. I don't know how it is in Europe or in the EU in general or in Australia, but I know some absolutely superb people in Australia, Wicklands and that whole crew, but it is changing. And we will be able to do what we need to do, which is early intervention. We have learned from all of the tragedy of the past, we've learned that we have to intervene very early. And I think that's something that we have to move forward. You know, we talk about the spectrum, the phenotypic spectrum of the disease. Patients have different mutations in the same gene. And some of them have a little more enzyme activity than others. And that's why you get the spectrum. So that's really what's going on. And that's why they kind of categorize it a little bit. But that's only a working model. We know every patient's unique. And that's something that physicians recognize. So I think I'm just kind of saying I lived through now over 60 years of being a geneticist. And I can tell you that, you know, I can't leave work because it only gets more better for patients. And all of us docs who do this work don't work for anyone else but the patients. And that's all we care about. And as we see the developments of the laboratory improvements and the whole genome sequencing, even in newborns, that's going on now in the US. And I know there's a lot of work being done in the UK. So I think that for young families who have the risk, and we've begun to do even premarital screening. We've done it in some of the religious groups that have consanguinity. I introduced it into Saudi Arabia. We do it in the super religious Jewish community. They have probably the most successful program. And I can just tell you that people will move that way, but it's worldwide that we have to help people, because we get requests for diagnoses from India, from Pakistan, from all over the world where they don't have that capacity. So I think the things that you're doing are so important, and I only want to represent, you know, that future, because I think you're going to see and maybe some of you are familiar with the recent diagnosis of a child with a fatal disease called carbamyl phosphate synthase type 1, was diagnosed in Philadelphia. And they did CRISPR and they corrected the defect. And it was not knocking out a gene, it was correcting the mutation. And that is very difficult because there's a lot of off-target hits when you do that, meaning you hit other genes as well. So we haven't advanced that, but it was done by the group in Philadelphia and the group in Berkeley who got the Nobel Prize for CRISPR. So I think we're seeing so many advances, and that really is what's important to think about. And I know that you're living with kids right now, and I'm hopeful that some of these advances will be applicable to kids who are living now. Reversal is tough. Prevention is easier. And it's true for every lysosomal disease where we have enzyme therapy or bone marrow transplant, whatever. The earlier you begin, the less, the more effective it is.
Well, thank you very much, Dr. Desnick. Again, we appreciate you sharing your unparalleled experience and insights, which I think are very pertinent. You know, the comment I'd make about spectrum of disease too is important because it's true. We think about different mutations having a different functional impact on the protein product, which is usually an enzyme, but not always, because there are exceptions in lysosomal disease. But of course, as Dr. Desnik well knows, the other factor is we have to consider the other, some at least of the other 25,000 or so other genes that are encoding proteins are interacting with the genes that are mutated. And we know this because we have so-called multiplex kindreds, where you have 2 or more children in the same family who have the same mutations in the same lysosomal gene, but have very different phenotypes. So it's even more complex than simply relating to the specific mutation itself. And of course, now that we have the technology to sequence the whole genome and we're understanding it at an increasingly rapid rate, I personally believe that an engineering response, and that is that we're going to sequence everyone's genome, I think, in the not too distant future, because the actual cost of sequencing is a few $100s. The interpretation costs a lot more. And of course, the challenge is going to be not that we won't find many diseases and make diagnoses, but we will find many variants whose functional significance we don't understand. So we will fix one problem, but there's another one we're going to have to be able to deal with. Well, yeah. I'll repeat it. Yeah. And just for the online audience, Dr. Desnik was pointing out the power of artificial intelligence, which of course can be used for facial recognition. We all know if you go to many airports now, that will allow you to board or not if you've misbehaved. And there are actually already programs for facial recognition for genetic disorders, which are getting better. I've actually I tried it on myself, which is a scary thing to do. So maybe I didn't want to know the answer, but it's always a good test with these things. But I agree, that sort of technology, I think, can be very, very, yeah, that's right, the cleft. All right, well, enough about us. I think that was a great discussion. Thank you very much. Because I really appreciate your insights. So I think now we're going to move on